Thank you for joining here, all the panelists. Very nice to have you here. So we are supposed to have 40-minute session. Because of lack of time, we'll try to close within 30 minutes. Can I have the next slide, please? So we are in an era where quality of care is better. We are able to get more equipment. We are able to scale up. We are able to reach more patients. That's a change, we are seeing it here. At the same time, investors need better returns. That's also mandatory. Unless service, they get better returns, the further investment won't come here. The third point is quality. Patients are having more knowledge about the medical care. The expectations are high, and there are more and more accreditation bodies monitoring the quality standards. So the question here is there any way we can align capital, cost and quality? So we have three panelists from three different backgrounds, all of them from healthcare. But if you look at their experience, it's absolutely fantastic. We have Professor Sarang, Executive Director from ISB. We have Mr. Gore from Advent International Operating Partner. We have Dr. Palin from Shija Hospital, Manipur, who is also a Guinness World Record holder for doing a surgery in the neck. That's an amazing journey, Dr. Palin. So we'll straight away move on to one clinical scenario. It's not a clinical scenario, it's a scenario in a hospital. I'm sure many of you can relate to it. There is a 150-bed NABH accredited hospital in Tier 2 city. They have got 120 crore PE fund. The expectation is to have 18% IRR in 5-year horizon. In year 2, new CFO proposes cutting nurse to patient ratio from 1:4 to 1:6. Nursing head of 14 years says that it's not viable, it's very unsafe. Fund nominee says, we are not asking you to be unsafe, we are asking you to be more competitive. So this is a real scenario. I'm sure many of you all have also faced this. Usually organizations say, don't reduce manpower, you have to optimize the manpower. I think there's a right word too, not the cutting the manpower. So the question to Professor Sarang start with, what does global evidence say about BNT and quality outcomes in similar markets? Is there any evidence you can talk about?
So Dr. Ilan, thank you for inviting me. Very important yet controversial questions and topics. Obviously, there is a lot of activity of private equity investments in healthcare. Unfortunately, the evidence on what's the impact of private equity is concentrated in some countries. As you can imagine, for a country like India, data is not publicly available easily. But for the markets for which data is, the impact of private equity on outcomes is a mixed one. Okay, so let me say there are systematic reviews documenting what is the impact on customer service, on patient safety, on clinical outcomes. And depending on how you slice it and dice it, what kind of methodology you use, you can get results from mildly positive to mildly negative to very positive to very negative. As you can imagine, even for patient outcomes, there isn't a single indicator. There could be multiple conditions, multiple comorbidities. So suffice to say, it's not overwhelmingly negative, but it is also not overwhelmingly positive. So in such situations, what do you have to do? You have to think about contingent factors. What are the conditions under which the impact is positive? What are the types of conditions and patients for which it is negative? So I'll pause here. It's an important question. Unfortunately, there's no clear answer.
Thank you. We'll come back to that particular point a bit later. We have a lot of things to discuss. I'm coming back to Mr. Raj. You have been part of operating team and now you are being part of investment team. Now we are talking about 18% IRR. I just wanted to ask you a very frank question. Is achievable to do this kind of returns by maintaining good quality care on the other side as an operator? Is it too much of pressure on the operator side to achieve this kind of IRR or returns?
First of all, thank you for having me here. This is probably one of the most important conversation we need to have, considering where Indian healthcare is at this stage. I think it's a false choice, the way it's been framed. Delivering 18% IRR in healthcare in India is absolutely achievable, but not by weakening the clinical backbone the way this example shows, whether it's cutting nursing ratios or compromising quality of consumables. That is not efficiency, that is deferring risk. Often impact of those decisions is shown long term in terms of increased complications, increased infection rates, poor outcomes, and therefore impact on outcomes as well as returns. If in this case, the quality doesn't survive eventually, I don't think the problem is the IRR target. I think it's how the model was executed. Because in healthcare, you can optimize costs for a while, but you cannot outrun poor quality in the long run.
Thank you so much. Dr. Palin, you are a clinician, started with a small clinic. Now you have got a 350-bedded Northeast first NABH accredited private hospital, and now you have also developed a medical college in your state. That's a fantastic story. From your point of view as a clinician, developed a healthcare ecosystem. If you listen to these kind of stories where this kind of investment, there is a potential to cause quality impact. There is a potential. We haven't concluded it. What's your thought as a clinician or not got a P investment date? If you are as an outsider, what's your thoughts?
Thank you very much. I have picked up 3 words. 14 years experience, unsafe competition. These are the 3 words I have picked up. Affordable excellence in healthcare is the biggest challenge so far the private sector faces right now. On the other hand, we are in the serious business of dealing with life, and it goes beyond budget, it goes beyond balance sheet. We have to deal with sufferings, life, trust, legalities, all these things. At the same time, we have to balance. It should be viable at the same time. The saying that unsafe was told by 14 years of experience. This we have to honor. This is one. And we are not asking to be unsafe. Why we are competing? Because competition is through 2 things in my perception. One is the clinical outcome, another is the experience outcome. When both are satisfied, more patients will come. So in this situation, in order to conserve the fund, she is advised to reduce the number of nurses. So according to me, I would like to suggest that we have to maintain the standard nurse-patient ratio, and we have to do more training, more skill, and more experience, because there are so many other income stream also. So we have to increase the satisfaction level. Then the loss will be compensated by the flow of patient, because the competition is through this only. That's how I feel. In my opinion, I'll not reduce the number of nurses and continue to improve the quality of the service and safety of the service. It is done through town hall and various other case management in our hospital. Thank you very much.
Thank you so much. We'll move on to one more scenario so that we can go and discuss on some other topics. So there is a corporate chain, listed group of hospitals. They wanted to invest 100 crores in oncology center of excellence. After 1 year of utilization, they have 45% of occupancy. At the same time, there is a competitor opened nearby. Now there is a problem. Finance is putting pressure on the hospital. CFO says, cut chemo daycare nursing ratios, defer senior oncologist hire, renegotiate drug procurement. At the same time, CMO comes and says, it's not possible. If you reduce all these things, we'll have trouble in providing quality. That's normal. Many occasions we see this kind of conversation. I wanted to ask Mr. Professor Sarang. So we have a lot of financial indicators to see whether these kind of investment yield right results or not. How can we prevent these kind of conversations? Why should a CMO come and fight for quality? Why can't a CFO himself know certain knowledge about these kind of things? How can we have some metrics to avoid these kind of conversations?
Let me just answer in two parts. A lot of initiatives that are focused on improving quality. The investment is up here, right up front and now, okay, very visible. The returns on investment when it comes to improved quality, improved patient safety, one, it is very difficult to quantify. It's also distributed all across the hospital and these accrue over time. So all of these are a problem for me to quantify and then further monetize what the value is, right? What do you do then? You need to look for operational metrics that sit somewhere in between the financial metrics and the clinical outcomes, operational metrics that you can track on a day-to-day basis, right? Just to take an example of nurses, right? Now, why would someone think that nurse-patient ratio can be reduced? There is an understanding that not all the work that nurses do today is value-adding, right? We are not saying nurses are doing bad work. What we are saying is that the systems are designed in such a way that, for example, a nurse has to walk 10 kilometers in a day in a hospital. Quite possible, 5 to 10 kilometers. That's value not created, right? That's value destroyed. So there would be such metrics that pertain to nitty-gritty of operations. If we were to track those and say, are we improving those? Then we could potentially reduce cost as well as maintain or improve quality at the same time. So there will be a bunch of these operational metrics that we should focus on.
Got it. Dr. Palin, as a clinician and hospital operator, if you are in that room, how do you feel? What's your thoughts? If the conversation happens between CMO and CEO, I'll come back to you as an investor. What's your thought if the conversation goes?
Thank you again. Here I have got this notice, competitor open nearby. This is one factor. And advise the nurse to reduce the ratio. This is another. And the negotiation for the drug procurement for the chemo. And the chief oncologist, he is not in favor of reducing because the patient deteriorates. So here I would like to say, for an oncology center, there are other streams of income, like PET-CT, surgery, diagnostic, bed. Maybe the income from the drugs may be good, but it's not that is not the only one. And most important is the patient improvement. Because there is a paradox for quality. We think that high quality is costly. In fact, low quality is costlier because it causes a lot of other problems to the patient, legal issues, and there is a tremendous loss by giving the poor quality services. So I should not. I have to have to hire the oncologists. At the same time, I will not reduce the ratio of the nurses so that we can deliver quality service and at the same time attract more patients. And another very alarming situation is the competitors nearby. So this is the time you have to act. Another thing, entrepreneurs don't back fund. They create their products liked by thousands. So we have to innovate in such a way that our products are liked and purchased by thousands so that we survive the market. Thank you very much.
Thank you. What's your viewpoint, Mr. Raj, from investor point of view, the same conversation, CMO with the CEO? How does your mind go?
So I think as investors or as board, the role is not to choose between CFO or CMO, but change the basis of discussion. In a specialty like oncology, the nursing ratio in chemotherapy or hiring of critical clinicians, these are not cost levers. These are enablers of patient safety, better outcomes, and therefore growth levers. What the board would do is ask the leadership or management to identify non-negotiable clinical thresholds or guardrails and agree that we would not touch them. Then board should push the leadership hard on all other cost levers such as utilization, procurement, scheduling, overheads, etc. If the business case is viable only by diluting clinical depth, then it's a wrong business case. Because we know that better quality, better outcomes is the enabler of trust, word of mouth, more footfalls, and therefore better returns.
Good. I wanted to deep dive a little bit more on investment in quality. Say if your portfolio hospital comes and says, I want 10 crores to ring fence for the quality improvement in your hospital. How do you decide those kind of investment for keeping the money separately for quality improvement? What parameters do you normally look into?
So first, as a board or as investor, we would ask two questions. One is, what are the patient safety parameters or outcomes that this investment will clearly move in the right direction? If the management has clarity and can explain, then the second question, which is, how would these outcomes or parameters move in 12 months or 2 years? And this is about measurability of those outcomes. If there is a clarity with management on those both fronts, then the question is not whether we should spend this or not, but the question or discussion should be how best to execute the plan.
Excellent, excellent. Professor Sarang, again I'm coming back to this point. In the West, US or UK, they invest a lot of money for quality improvement projects. Also, they see the results directly, reduced readmission rates. There are a lot of clinical parameters, they see it in the West. Do we have any data in India, or is there any evidence we can adapt in Indian healthcare system? What's your experience? Is ISB doing anything on this particular subject?
So, in more developed economies, where you have a very mature payer system, right? There are these quality metrics and pay-for-performance mechanisms are being developed, are being implemented. In those settings, investment in quality makes a clear business case because you can calculate how much readmission rate would get reduced, how much hospital-acquired infections would get reduced, and as a result, will my payment increase to what extent? In a country like India, where still a lot of payment is out of pocket first, and second, even for insurance payment, we don't have very good pay-for-performance mechanisms. Also because performance measurement is not there. We don't have outcome reporting mandated, right? So in such cases, I think the discussion between the CFO and the COO could be moderated by saying, what are the win-win situations, right? How would I make better revenue per bed if I were to reduce hospital-acquired infections? We all know that first couple of days of the patient in the ICU, you get a lot more revenue as compared to, let's say, a fifth or a sixth day if they are there only because of hospital-acquired infections, right? So we need to create and build these internal ROI calculators to say what are the win-win situations, and that requires information from the operational side, from the clinical side, as well as from the financial side.
Excellent. Do we have any questions from the audience to the panelists before I move on to the panelist again? Anybody wants to ask any questions? Good. Dr. Palin, is there any one policy decision or one innovative idea by which Indian healthcare can move towards high quality care, high quality patient care. At the same time, we maintain good financial stability in an organization. Is there any one thing you can suggest as a closing remark? I'm going to ask the same question to all of you. I want to start with Dr. Palin. Any one innovative idea, one suggestion, one metric you should closely follow?
Yeah, from my direct experience, in fact, we have started as a monopractice, then super specialty hospital, then a private medical college, nursing college, and paramedical institute. And our medical college is 5 years old. Now, we had tough time financially, but in the beginning, because expenditure was not more than the income, revenue. And we had to work closely, and things are better now. And you know, Manipur is turbulent rather for the last decades, many decades. In the turbulent environment, we try to go, and because of the situation, the market size also is decreased. We have extended to Myanmar, and we have treated more than 5,000 Myanmar patients, including 2 kidney transplants. Now the border is sealed following COVID, Corona, and at the same time, recently, because of the situation, socio-political situation. Now, we are thinking of expanding to other states. We have planned for expanding to Agartala, Tripura, and we have been allotted 29 acres of land, and this is to replicate the same thing what has happened in Manipur 40 years. We'll try to compress it 8 years. So this time we may be requiring the private equity or some other funding, because we cannot expand that fast, because we have somehow we manage 40 years incremental and sometimes sudden jump, and every time we jump there was some issue with us, financial issue. Now it is a little stable, and another thing is Manipur is interface with India and Southeast Asia. India's Act East policy to connect with the Southeast Asia, its working is going on. Only because of the political situation in Myanmar, it is not happening. Once it happens, I think we'll have the advantage. Another thing is Tripura is surrounded on 3 sides by Bangladesh. 2.5 million Bangladeshis are coming to India for healthcare reason. And this is another area where we can take the medical tourism also.
Thank you. Thank you.
So,
Raj.
thank you very much.
Thank you. Mr. Raj, your point, any one policy decision where we can balance both?
If I had to pick one thing, it would be standardized outcome measurements across providers in a transparent manner. It would change 3 things. Patient would choose better, payers will contract better, and capital will allocate better. We've been regulating prices, but we've not regulated outcomes. I don't think we have a cost problem. I think we have a value visibility problem. Even if we do it for selected set of procedures, it will go in a long way to move quality from a more moral, aspirational goal to an economic enabler. Because we know that quality is the most effective way to control cost in the longer run and compound returns.
Excellent. I think it's a value-based healthcare system is the way to go forward. What about Professor Sarang? What's your thoughts? The final conclusion line.
So I completely agree. The one change that is needed today is mandatory outcome reporting. Okay? I have not heard anyone who says they don't agree with this. Okay? So the big question is how? And let's start from the top. Which is the regulatory body today that can mandate outcome reporting? I don't think there's an obvious answer, and that's where the problem lies. Right? You talk to IRDA, they'll give one answer. You talk to MOHFW, they'll give another answer. You talk to NHA, they'll give another answer. So I think this needs to be sorted out. Second, I hear often, how do we trust the outcomes that are reported? Right? Because I am obviously better than everyone else. Right? But once reporting happens, how come someone else is better than me? So the mechanism that we create, the data mechanisms that we create have to be trustworthy. Probably we can use technology, blockchain, I don't know, those kinds of things. Third is we have to make payers think strategically, right? Which is, if they are increasing in their market share, I mean, take even PMJY, right? Could they use their market power to improve outcomes rather than finagling on what's the package rate, similar to what Raj was saying, right? We need to move beyond prices, right? Now, I will also say that there's a capacity gap in the country today, because for me to mandate outcome reporting and pay on that basis, I need to know how to do case mix adjustment, right? Someone will claim that my case mix is much more adverse than someone else's. You need statistical prowess, you need how to analyze the data, you cannot borrow those models from the West. So that capacity also needs to be filled. So I'll stop there.
Excellent, thank you so much. I think we are on time right now. I think it's 30 minutes gone. Perfect. I think we should end the session. Thank you so much for being here. Very valuable insight. Thank you so much.
Why don't